Good morning, everybody. I'll be discussing tamponades, propping it right. To tamponade something means to close or blockage. And an ideal tamponade would be something which would be an ideal vitreous substitute. It should mimic the vitreous which is present in the body and the positive qualities of vitreous like transparency, elasticity, buffer capacity, and biocompatibility. But it should avoid the negative values which are liquefaction and biodegradation with age. We can classify these into three types: gases, liquids, and polymers. Gases being air and expansile gases, liquids PFCl, semi-fluorinated alkanes, and silicone oil, and polymers include hyaluronic acid and collagen. The most important aspects about this is first to make the correct choice of tamponade, and secondly to do it right to get the best visual outcome. An ideal substitute should be easily manipulable during surgery, should maintain the intraocular pressure within the physiological range as well as support the retina, allow movement of ions and electrolytes, should be optically clear, ideally be a one-time implantation, be non-toxic and biocompatible, and practically it should be easily available, stable during storage, injectable through a small syringe, and available at a reasonable cost. So the most freely available tamponade to us is of course air. The surface tension keeps the retina opposed and attached. It's non-expansile, which is a major advantage because there's no concern about causing traction to inferior retina and causing new breaks when you inject air in a case. But the main disadvantage is it's extremely short acting. Other gases provide internal tamponade. They have high surface tension, replace the glow volume, and they reduce intraocular currents. These include SF6, which is sulfur hexafluoride, which is the non-expansile concentration is 20%. It lasts for about 2 weeks, and bubble is relatively large in the first few days to give a sufficiently large tamponade, even if the breaks are widely separated. Perfluorocarbon gases, they have the generic formula CX2X plus 2, and X is normally from 1 to 4, and this is important because the longer the carbon chain, the lower the solubility in the water, and which causes the longer intraocular longevity of these tamponades. In fact, 1 ml of C3F8, which we routinely use, expands 4 times and stays for 6 to 8 weeks in the eye. This is a busy slide, but just want to point out air longevity maybe about 5 days, and the maximum would be perfluoropropane C3F8, which would last from 6 to 8 weeks. The 3 phases in which a gas bubble stays in the eye are expansion, and goes on to equilibration, and then it dissolves. So expansion is most rapid in initial 6 to 8 hours and is similar for all gases. The gas reaches its maximal size when the gases diffusion in and out of the bubble equilibrates. And for SF6, this happens in 1 to 2 days after injection, and C3F8, it takes 3 to 4 days to reach the maximal expansion. So we need to take certain precautions when we use gas in an eye. We should have a low threshold for suturing, which I'll be showing in a video, and keep some gas ready in a 2 cc syringe in case of hypotony, which can happen after removal of the infusion cannula. In GA cases, we need to be very careful, and nitrous oxide should be discontinued for at least 15 minutes prior to gas injection to avoid interference in the desired gas volume bubble obtained. So this is just a very short and simple video. And you can see the leakage. So this is what we are talking about. You should have if you are seeing leakage through this port, then you should put a suture. Other thing about the suture is it should be partial scleral thickness, because as we once discussed, if full thickness suture would be a conduit for organisms to enter into the eye. And now we are putting this 29 gauge needle in, and this is going to help in the flush, starting the gas flush. So these are just simple steps, and the next video is an external video showing the assistant injecting the gas for the C3F8 Air Exchange. So the surgeon is holding the 29 gauge needle in the eye, and the plunger has been removed from this. You see the plunger is removed, and the sister is injecting, and once there's just 10 ml is over, it normally be 10 ml is over, we stop and clamp. And this is the important thing at the conclusion of the surgery also, when you are removing, this of course you can see the leakage again. We should press it longer, but we wanted to just show if there is leakage, Now the eye has become hypotenuse. So just to have a good outcome, you don't want any hypotony, especially in diabetics and all where there is chance of bleeding. We want the eye to be a slightly firmer side. We don't want it soft at all. So here we put a suture, or we could try the new technique which Dr. Abhishek has told us today by just putting a, and then we inject a little bit of gas from here, and this is going to help to make up the intraocular pressure. And with the bud, we are feeling the IOP and closing the case after this. We move on to oil. Silicon is made up of repeating units of siloxane, which consists of silicon and oxygen molecule. And it's a hydrophobic substance with specific gravity less than water, 0.97, and refractive index of 1.4, which is less than that of vitreous, which is 1.33. Indications are detachments with PVR, patients who have difficulty in strict postoperative prone positioning, patients who need to travel by air shortly after surgery, large tears, inferior breaks, but there's no fixed criteria. It of course depends on the surgeon's preference also, which cases go for silicone oil. The two viscosities which we commonly use are 5,000 versus 1,000, and of course it's more difficult to inject as the viscosity goes up, and the ease of removal also is higher as the viscosity goes down. Important thing is, of course, the risk of emulsification is much less in the higher viscosity oil, which is why if you want a permanent tamponade, we're not going to be able to take out the oil, then we would prefer the 5,000 oil. But we should remember the tamponade effect is same among these two. PFCl is a synthetic fluorinated hydrocarbon which consists of carbon-fluorine bonds. It is very optically clear, which allows us to do manipulations, and the high specific gravity allows us to flatten retina under it. And like Dr. Cyrus explained, sometimes we can avoid making a posterior retinotomy because we do a sandwich technique with PFCl. Currently, of course, this is controversial, but generally we use it for intraoperative maneuvers because there's toxicity if we leave it for longer periods in the eye. And always there's a dilemma that if you have inferior PVR, what should you do? So the heavy tamponade concept is come in, because as we discussed, the conventional oils all have a specific gravity of 0.97, which is lower than water, hence they float. So inferior retina doesn't get an ideal tamponade, and if you have a slightly underfilled oil bubble, it leaves a large area of inferior retina unsupported. So there are two ways to have this heavy oil. One is a double fill. So double fill is a combination of silicone oil and semi-fluorinated alkanes, and the goal is that a light silicone oil will support superior retina, while the heavier SFA supports the inferior retina. Or you can have a heavy silicone oil which is created by combining these two in a way to create a homogeneous solution. So this is also a busy slide, but that basically commercially available Densiron 68 and Oxane HD. These are the two which are used, and you can see the specific gravity 1.06 and 1.02, which is higher than water and more than conventional use silicone oil. The HSO, the heavy tamponade study, is ongoing, and preliminary results were published in Acta Ophthalmologica in last year. And this compares two groups, 46 eyes I think in each group, with Densiron versus conventional silicone oil. And the eyes they chose were with inferior and posterior PVR, grade C or above, but they found no significant difference in the two groups regarding anatomical success or the visual outcome. So this study was not very encouraging, but they are going further with this study. A word about intraoperative precautions with oil use. The inferior PI is a must in aphakic eyes, and this allows the aqueous to flow and prevents the oil from coming into the AC. And when we are doing it inflamed eyes, we have to be careful, because you can see sometimes the iris can bleed a lot, and you can have a hyphema while making this inferior PI. Other precautions, of course, avoid overfills, because it can lead to extremely high IOP, and you may need to do a silicone oil tap. Underfills you need to avoid to get a good tamponade. And in case of the special precautions, the PFCl oil exchange infusion needs to be monitored. Now, basically what happens is when you are injecting oil through the cannula, there is a tendency for that cannula to pop out. So you need to, I'll just show a video about that. This was a very complex case. So this had a hybrid surgery. On the top you can see 25 gauge, but you have a suture 20 gauge cannula with a 6 mm cannula here. So here we can proceed with there's PFCl, and the laser has been done, and the flute needle is inside the PFCl bubble, and oil is coming in through the 20 gauge suture cannula. So you can see the PFCL bubble getting smaller, and right at the end we use a brush so that we can touch the retina and we're not scared about concluding the case. This is another case of a GRT. Just a short video. Basically, in case we are using all small gauge instruments, we need to be careful. So we don't attach the oil to the tubing itself. So just see the maneuver. You take the oil and very carefully you have to just place it and hold it securely. So this prevents the infusion from popping out while the oil is being injected. So basically this is a comparison which we already discussed. Postoperative concerns, of course, are the intraocular pressure, shallow AC, tamponade entering the AC and causing corneal decompensation, cataract formation, IOL capture or dislocation, and keratopathy. So another thing, if we don't suture, I think with oil we must suture the, in small MIVS it's important to suture the sclerotomies. And in case of IOLs, decenter with gas, strict prone positioning and lowering the IOP may help. This was a case of angle closure glaucoma with oil, and you can see making a small PI got the pressures down in this case. So we have discussed the various substitutes. None are perfect, pros and cons we have to go into, make a right choice, and small surgical tips can optimize visual outcome and reduce complications. Thank you.